Hello, everyone. Welcome to day 3 of the MMRC 2023 Midwifery Research Symposium. I'd like to begin by offering a land acknowledgement. I'm joining you today from the traditional territories of the Anishinaabe and Haudenosaunee nations, and this is land that's protected by the Dish with One Spoon Wampum. And it's directly adjacent to the Haldeman Treaty Territory and is also part of the lands that were subject to the Between the Lakes Purchase. Offering a land acknowledgement is a way for us to formally recognize and respect Indigenous peoples as the traditional stewards of this land, and to respect the enduring relationship that Indigenous peoples have with their traditional territories. And it also creates an opportunity for us to consider how we can act personally to support truth and reconciliation. As a settler here on Turtle Island, I'm committed to actively reflecting on and fulfilling my treaty responsibilities, and I offer this land acknowledgement in the spirit of reconciliation. Part of the legacy of colonization is that many Indigenous people, both those living in Indigenous nations and those living in urban settings, do not have access to appropriate, high-quality, culturally safe healthcare. And the silencing of Indigenous midwives that's occurred over the past century has contributed to this. And the powerful work that's being done by Indigenous midwives across Turtle Island to return Indigenous midwifery to Indigenous communities is essential to reconciliation. In today's symposium panel, we're going to hear about some of the ways in which midwives are working in new models of care to support families in the first weeks following the birth of a new baby. And as I expect we'll hear, this is a critical time in families' lives, and midwives can play an important role in supporting a healthy foundation upon which parents and families can thrive. The benefits of midwifery care provided by Indigenous midwives can play a key role in supporting the strengths of Indigenous families. And as we think about how we can continue to move forward within the profession of midwifery in Canada to support truth and reconciliation, actively supporting the growth of Indigenous midwifery is one of the key ways that allies and accomplices can work with Indigenous people to support reconciliation. So thank you again to everybody for joining us today. We have a variety of different presenters and topics each day during our symposium this week. So please make sure that you check out the program and the schedules and the speaker bios on our website, mmrc.mcmaster.ca. And we are also recording all of our presentations. So a video of today's presentation will be publicly available after the symposium on our website. We are also trying something new this year where we have an online discussion happening in parallel to the Zoom webinar, and this is on Padlet. You'll see in the chat a link for this, and so you're welcome at any time to join that discussion by posting onto the chat in Padlet. So I'm really excited today to be hosting a panel discussion on midwife-affiliated, midwifery-led postpartum care programs. And I want to give a really warm welcome to all of our panelists. We have with us today Natalie Kirby, Lauren Columbus, Lindsay McDougall, Chantal Bourbonnais, and Stephanie Zahir. And I'm going to ask each of our panelists now to introduce themselves. And I will start with you, Chantal.
Hi, everyone. My name is Chantal. I'm a midwife who recently joined the postnatal home care program at the Montfort Hospital. And I've been working as a midwife in Ottawa for the last 20 years.
Thank you. Lauren?
Hi, everyone. My name is Lauren. I'm a midwife in London, Ontario, working with the T.I.M.E program, which is an expanded midwifery care model. And I'm the current executive lead for the Department of Midwifery at LHSC.
Thanks, Lauren. Natalie?
Hi, I'm Natalie. I'm also a midwife, and I am the clinic lead for the an EMCM, which opened in 2018. I'm the clinic lead for our Well Baby Clinic here in Collingwood.
Great, thank you. Stephanie? Oh, I think you're muted, Stephanie.
Sorry. I'm Stephanie. I've been practicing at Oak Valley Health at the Markham site for the past 10 years and coordinating the Midwifery-Led postpartum program since 2020.
Great, thank you. And Lindsay?
Hi, everyone. I'm Lindsay McDougall. I'm currently the lead midwife for a well newborn and parent clinic at Kingston Health Sciences Center, and a practice partner at Community Midwives of Kingston.
Thank you. And I just would also want to encourage everyone in the audience to make sure you do check out the full bios of our speakers on the MMRC website, because we have more details there about all the accomplishments of the people who are speaking with us. So I'm going to move into the panel discussion right away. And what we're going to do today is we'll hear from each of the panelists for about 10 minutes. And then we should have quite a bit of time at the end to welcome questions from the audience so that you can ask your own questions about anything that isn't covered in their presentations. So Chantal, I'm going to start with you. And if you can maybe tell us briefly about how your program works. And then we are also interested in hearing about what you see as the benefits of your program for clients, for the hospital, and for midwives.
Sure. So our program at Montfort Hospital, which is just on it's in Ottawa, and we serve a population of Francophone and Anglophone, urban and rural, has been established since 2017. Basically, we are, well, thank you, pandemic. The program took a big hit during that time, but we are slowly building it back up. There's a full 4-time equivalent to the program, and presently we are filling it up to about 70% of that capacity. We are midwives who primarily only work in the program. We're employed by the hospital, obviously. And so at this point, I'm not doing any births. I'm not seeking any other roles, and neither are the other midwives who are working in the program. There are some casual midwives that I forgot to talk to you guys about, but they are still working as midwives and helping out here and there as needed. The program is ran pretty much by, well, midwives, obviously, but also with the staff at the hospital, pediatricians, obstetricians, and nurses who kind of like always looking at clients who've just recently given birth under the care of OBs or family docs to see if they meet the criteria for our program. And therefore, if they do, clients are presented with the option of early discharge. And so early discharge, what it means in our program at Montfort is that if you've given birth vaginally, you can, and if you qualify, you can leave the hospital anywhere between 6 to 20 hours after you've given birth. And then if you have had a surgery for birth, then you can qualify, but you must leave after 24 to 28 hours. So they try to keep it into a shorter window of time just so that we're still considered into early discharge. Like I said earlier, our mix of clientele is anywhere from urban people giving birth. And then there's also Montfort Hospital, as you might know, is a hospital with a Francophone penchant. I don't know how to say that in English, but pretty much there's a focus for us to work and serve that clientele of Francophone clients who are along the corridor between Ottawa and Montreal. So that's who we serve. What else? Pretty much our day consists of, early morning meetings amongst midwives, distributing the workload, and then going in to see families, moms and babes, doing postnatal care, as all midwives know, weight checks, Billy follow-ups, breastfeeding support, chest feeding support, and then organizing follow-ups appointments. So typically, when women are qualifying for the early discharge program, they will have access to a midwife for the first 7 days. So it's like as if we take charge of their care for them and their newborn. They are not expected to go and seek out their family physician or a nurse practitioner or go back to the pediatrician. If there's anything that steps outside of normal at that point when we're doing our visits, we are the one responsible for seeking and organizing that care. Pretty much the benefits, I would say, for families is that as midwives, we go to their house. We very quickly strike up a rapport with families, and we'll be able to, gain trust so that families feel comfortable in us assuming care. And because a lot of the time they're like, well, I needed to go see my doctor first time around very shortly after birth, and we still need to do that. So we do a very thorough assessment and put families at ease. And then we, like I said, organize follow-up appointments either over phone or in person. The benefits is that women don't need to leave their homes clearly. We increase rates of chest breastfeeding, high satisfaction from feedback from families who participate in the program. Women just can't get enough of this program. Obviously, the benefits also for hospitals is that it lowers the stay for families in hospital, therefore reducing cost, reducing risk of infections, just like any reduced stay in hospitals for that sake. And we also reduce readmission for newborns and moms because we keep people in the community and we network as midwives differently. So that's what I would have to say about the program.
Wonderful. Thanks so much, Chantal. I'm going to turn next to Lauren. And Lauren, I'll ask you the same questions. If you can describe for us briefly how your program works, and then share with us what you see as being the benefits for clients and hospitals and midwives.
Yeah, absolutely. So our program, the T.I.M.E program, is actually full sort of antenatal as well as postpartum care program, but it's specific just to the maternal-fetal medicine population. And so here at LHSC in London, we do about 6,100 births a year, of which anywhere from sort of 1,200 to about 1,500 are admissions under the maternal-fetal medicine team. And so our population is exclusive to that group, and it's about providing sort of this thread of continuity across the antenatal period as well as the postpartum period, but does not involve intrapartum care unless it is a planned booked C-section, which we do attend. And so this care, there are 3 midwives working in this program, and we're based out of the obstetrics and gynecology ambulatory care center at our hospital. We have 2.0 FTEs, and we provide a mix of attending the antenatal appointments for people, and then we provide 6 weeks of postpartum care that's based out of people's homes. So we do that as well, similar to Chantal, entirely based out of home at that point. And so we become the primary care providers for the infant and the maternal or birthing person, typically upon discharge from the hospital. But prior to that point, they are under the care of their MFM. And so we don't have sort of an MRP or management status for their pregnancy antenatally, because typically these are all individuals who have fairly complex medical care needs that would not have sort of fallen into the typical scope of midwifery care. Now, recognizing, I mentioned that they take about, anywhere from 1,200 to about 1,500, 1,400 admissions a year. We obviously do not have the capacity to see all of them. While that would be very lovely, we currently see probably about 10% of that population, and that's just the capacity that we have. So we did have to come up with a referral criteria. So within the larger population of MFM patients, we really specifically wanted to focus on the social determinants of health. And so our referrals that we get from MFM to have people join our program are really a very targeted population. And it predominantly involves, as I mentioned, social determinants of health. So typical things like equity deserving populations, people with, mental health needs, unstably housed, substance use, really significant sort of additional mental health histories that include, repeated loss or histories of trauma. We also focus on newcomers to Canada who just may need help navigating the system, as well as bereavement cases. And that can be bereavement, at the time of the loss, we'll sort of get a referral at that point and then provide care from that point onwards, or people who are making decisions around termination based on fetal conditions, or who may have bereavement, over time. So yeah, as I mentioned, our capacity is around, about 10% of that caseload, but I just obviously want to point out that truthfully, closer to probably 95% of the patient population for maternal fetal medicine would actually meet that criteria involving, equity deserving populations and social determinants of health, because the overlap is so significant in terms of, pregnancy complications and some of those social determinants. So truthfully, the majority of their population could really benefit from this program. And so I'm very happy that we even have the capacity to provide the care that we are providing to this sort of sliver. But really, once you start getting involved, you realize just how high the needs are in this population for a really good supportive program like the T.I.M.E program. So in terms of sort of some of the rationale for setting up with the MFM population exclusively, most of that came from the literature and the fact that MFM patients are people who had complex pregnancies, either for medical reasons for the birthing person or for the fetus or neonate. We know that this population accesses significantly more care in the postpartum than the general population. And that includes emergency department visits of all types, both for the birthing person and the newborn. And they also seek a lot more primary care as well through family doctor visits or other sort of specialist referrals and outpatient visits. So part of the goal was to recognize that that's a huge drain on the healthcare system for a lot of reasons, and also probably reflects the fact that this population experienced a high-risk pregnancy, had a lot of anxiety for the duration of that pregnancy, and then they sort of get discharged and have essentially no or minimal follow-up aside from, trying to get in with their family docs. That's a really tough transition for people who are being maybe seen daily or who were admitted to the antenatal ward for prolonged periods of time. There's a really big challenge with this, after discharge, losing all of the supports that were provided in the hospital and sort of being left to essentially flounder a bit once they're home. So our goal was to address that, both that patient experience, but as well as the costs that can incur on the system. And we also know from the literature as well that the MFM population has significantly higher rates of postpartum mood disorders, specifically including anxiety and depression. So we, hypothesized that providing this type of care for at least the first 6 weeks postpartum would at least maybe address some of that anxiety, and we could sort of help set people up with better services in the community. Also, technically, though we are located in London, we actually do take people from all across the Southwest region. So this includes, Windsor, Sarnia, Chatham, all the way up to Owen Sound, because we do care for individuals who will stay at Ronald McDonald House with infants in the NICU. And that's just because obviously the MFM division at LHSC takes referrals from that whole region. We know from the literature as well that the population of people who are from outside of a community but staying in that community because their infants are in the NICU, they also access emergency services at a much higher rate because they have no primary care provider in the region. So we consciously included them in our catchment for that reason. And so we provide 24/7 pager access for people in the program, both antenatally and postpartum. So very, very similar to how community midwifery practices work. And we then do a pretty similar schedule of visits in the postpartum after they give birth and head over to the postpartum care unit. We try to see them every day, that they're there, predominantly making sure that the care plan is being followed and providing chest and breastfeeding support, and making sure that we're all set up for that transition into the community. So this can include things like having translation ready, CAS involvement in whatever capacity they've been flagged, figuring out specialists, follow-up appointments, and that we're all aware of them and when they happen. And then we shift to seeing them in the community once they get discharged home. So I would say that the benefits, first and foremost, is that this is a patient-centered experience, and it's about providing the absolute best experience for high-risk families. And then secondly, it's about system efficiency as well, and reducing some of those unnecessary readmission costs or emergency department costs. And it's also providing the appropriate level of care to the appropriate patients at the right time. So we recognize that someone high risk can see an MFM for the high risk needs, and then maybe have a low risk provider providing the care for all of the sort of low risk needs that they might have, rather than just saying, well, you're high risk, so everything having to do with you, you'll get care from a high risk provider, when we know that our system isn't really well set up. Our MFM team, at least here locally, and I'm sure this is the case across the province, they are, have far more need than they have space available. And so they just find, they, even if they wanted to spend as much time as they feel like people deserve to have for complex counseling, they simply cannot see the number of referrals that they need to if they were to do that. So that's where they pull us in, and we can provide sort of at least the antenatal and postpartum care that might not need to be with a high risk provider. And the same goes for a newborn. You can have a perfectly healthy newborn born to somebody who themselves had a lot of maternal medical conditions. And then just before I wrap up, I would say one of the other benefits is the interprofessional collaboration aspect of the program, that is, a little bit outside of the patient, experience, but is really a huge deal to have the presence of midwifery in the hospital, having a space and a role as part of the care team, and being a really valued member of the care team, even outside of our typical colleagues of OB and nursing, but moving into sort of cardiology, ICU, lots of other services. And so I think that's a really important part as well. And legitimizing the home as a location for outpatient services. So all of our home visits are done as outpatient visits, registered through the hospital, but provided at people's homes. Yeah.
Thanks so much, Lauren. Really interesting to hear about something that's, quite a different approach than lots of the other existing programs. Natalie, would you be able to share with us now a little bit about your program and again, what you see as being the strengths?
For sure. I kind of don't want to follow Lauren because that was the most impressive thing. So I am the clinic lead for our Well Baby Clinic in Collingwood. So we're partnered with our hospital as well. Our hospital is a level 1B. So we do about 500 deliveries a year. About 200 of those deliveries are with our midwifery practice group. And so we don't get too involved with those cases. And the other 300 deliveries will all sort of filter through our clinic. And how much care we provide them depends a little bit. So we would either facilitate early discharge, we would either do management of hyperbilirubinemia and follow-up billies. We would either be doing following for weight checks, for an IUGR baby, or breast chest feeding support. And our involvement will range from just doing the early discharge and then they go back to their family doctor, or we take care of them for the first 6 weeks if they don't have a primary care provider. So it just depends really on what that particular family's needs are. And then we'll fill in the gaps sort of as we need to. We're a little bit of a hybrid as well in terms of what we do. We are I like to sort of say that we provide postpartum midwifery care to the physician patient. It's sort of the easiest way I think of explaining it, because postpartum midwifery care should be the gold standard. Like that is the care that everybody should be able to access. And so we do that, but we also do a lot of group programming. So we facilitate mental health support groups, and we facilitate a group postpartum like social group. We do a lot of workshops and things like that as well. We do attend cesarean sections to facilitate uninterrupted skin to skin in the OR, which in a level 1 hospital with two nurses on, we don't have that capacity if you don't have a midwife there. So we sort of work to fill in the gaps of what is needed in our community and add that like extra layer of care that midwives provide. And we do that like in different ways. We are funded for a 1.5 full-time equivalent. Although we kind of heard maybe through the grapevine that we are approved for an expansion. So we're going to soon be moving to a 2.5, which is fabulous, because the services that we currently deliver, we would just like to be able to deliver more of them, because ultimately we're pretty saturated, and our performance measures have been awesome. So unlike Chantal, our program like took the opposite of a hit in the pandemic, that we really hit a huge boom. The way that we're currently structured is like I'm a 1.0 and I am a staff at the hospital, and the remaining 0.5 FTE is shared amongst a group of midwives, but they remain independent contractors. And we've done that for a few different reasons, is with the exception of me, who stopped doing deliveries less than a year ago. Everyone else works in the MPG and in the EMCM. And so having it not be staff, having it be like flexible on when they do their hours and things like that, allows people to kind of pop in for a week when they're off call, and then the other person, they pop out for a week, with me kind of coordinating all of that to get all the work done. We are open 7 days a week, but we're not on call. So we don't provide any call service for right now. And I think that one of the really big successes of our program is that we work really well with our hospital, and they've given us a lot of autonomy. So they've sort of said, like, listen, you know what you're doing, like, we trust you, we're here to support you, but run the program in the way that makes the most sense for everybody. So as the clinic lead, I do a fair amount, like I manage all of our social medias, I do all of our payroll, all of our scheduling, so it's sort of an interesting role, because you're a little bit of a jack of all trades, operating in a bunch of different ways, which is similar sort of when you're practice partner. And so we're taking a lot of those skills that we did there and bringing them over here. I did do the Master's of Health Science Education from McMaster, and my thesis was about collaboration. And I really believe in it. And I really believe that when we are all using our skills and scope and complementing each other really well, we're going to deliver the best care to the patient. And so that is sort of what we really try to do, is fill in when we can, by working with the family doctor, working with the nurse practitioner. Our office is offsite, like out of the hospital, and it's actually in one of the obstetrician's offices, which is great because they send me something down the hall, and we have a really amicable, easy interdisciplinary back and forth for things that we do. Like, we also do a lot of outpatient NSTs, so people don't have to go into the hospital nearly as much. And I think that the reason we've been so successful and welcomed so much into our community is because the program is very good for everybody. So it's excellent for people who want to access postpartum midwifery care, but either are sitting on our wait list for an MPG at the MPG, or they're, you know, they're medium and they're high risk and they aren't appropriate for midwifery care, but they still want that postpartum care. So it's been really great for people that way. We've been able to increase our breastfeeding rates in the community by having access, and, you know, so people like the community is really loving it. The hospital also really likes it because they get to save money on their global budget by getting, you know, early discharges, and people aren't coming back in all the time for outpatient blood work. They don't have to come back to the hospital for a billy, you know, like we can do all of that, keep all of these people out of the acute care setting. And so the hospital loves it because we get to do a lot of those things offsite. And then the midwives really love it. I was a full-time practicing midwife for years, and I love the model of care. And then I had 2 little kids, and I was like, oh my goodness sakes, like I'm not good for anybody right now, because I'm staying up 24 hours and I'm coming home and, you know, I'm trying to parent and I'm not doing a good job there. And so I just reached a point in my life that I really felt like I need to not be on call so much. And so it's been very good from that angle, but it's also been really nice for my colleagues who continue to deliver care in the MPG. But they get to come over and do things in the Well Baby Clinic, and they really like it too. So it's been really successful for everyone, which I think is why we've had so much buy-in and so much business sent our way. And the last thing I think that has been great is we've increased the visibility of midwifery work. We share the EMR with physicians, and I think they maybe didn't really know what we used to do before. And there's a real respect and a real mutual collaboration that has grown tremendously in our community since we've opened, and they see what we do and they see how we do it. And that's, I think, why it's been such a beautiful program to be a part of. I can't tell if it's me who's frozen or if somebody else is frozen.
I think Liz might be frozen, so maybe we could go to Stephanie next.
Okay, well, hopefully Liz joins us again soon. I think I'll be a little more brief because everyone has kind of said a lot of the same things. Natalie, I really identify with you, why I love this role so much. So I am the clinic lead for the Midwifery-Led postpartum program at Oak Valley Health. We used to be known as Markham Stouffville Hospital. So we started in April 2020, which coincidentally was the start of the pandemic. It was very well received. We first started as an early discharge program. We were very, very busy. People really wanted to get out of the hospital. We had a policy at that time that partners had to leave 2 hours after the birth. So we had people going home all hours of the night. So we were really happy to support that. So we did that for about 6 months, and we started to notice that more and more people were calling us for repeat home visits because they couldn't get in with their primary care provider. They couldn't even get through on the phone. Offices were closed. We all know what that was like during that first lockdown. So we quickly realized that we needed a space for people to come to with their babies just to be more efficient. So on that note, our catchment is East York, and it should be more like West Durham region, but it really extends all of Durham region. We have a pretty good reputation at our hospital, so people will come from as far as Bowmanville to Markham for care. So the driving just got to be a little too much. So we really had to tighten our boundaries actually as we grew, just so that we could manage. So in December 2020, we opened the Family and Baby Clinic. It's in the hospital. We first started by sharing space with our breastfeeding clinic, and we did just appointments in the afternoon and did our home visits in the morning. About 5 months after that, we actually got moved to the alongside midwifery unit, and that was it was a really good move for us, not only because we got windows, but because we're on our midwifery unit, we can be a really good resource when the acuity is high, either on our unit or on the physician unit, which is just down the hall. It's also really nice to be near our midwifery colleagues again, I have to say. So we see basically that it's been great. The physicians and the nurses will flag the families who don't have any follow-up care. So all that kind of referral process, booking the appointment, that gets done by them before the patients leave the hospital. And so they'll come see us either the next day after discharge or whatever is clinically needed. So initially we thought we would just see people who just didn't have a family doctor, like those unattached patients. But we thought as COVID kind of eased off that we wouldn't be seeing people who have a doctor, but that hasn't been the case. It's still really hard in our community to either find primary care or to just get timely appointments. So we're seeing about 35% of all the families that deliver with a physician at our hospital. So just to give you some perspective, that translates to between early discharge program and our family and baby clinic, we saw about 1,700 dyads last year. So we're clearly outgrowing our capacity. Yeah, we're pretty swamped. It's 7 days a week. We see people up to 1 month if they need it. We are going to soon be moving to group care for the 2-week and 4-week appointments, just to try to see more people. And we're going to also be starting a peer support group to focus on mental health, just because, again, like some of you mentioned, we've seen a real gap in that mental health care in our community. And the people who might not have a diagnosis or like a psychiatrist care setup, they just kind of get lost, right? So we're trying to meet that need as well. And in the past 6 months, we started, it's really an honor to be able to do this. We see families who are in that bereavement and grief process. So we see them at home and we try to get those families out of the hospital early if they've had a loss, because really if things are well clinically, there's no need to stay here 24 hours. So we've been offering that as well. So I think you've all mentioned the benefits. Obviously, patients love it, midwives love it. We have 2 FTEs. I'm the only full-time person. And then it's kind of neat here because we have some of our staff in the program can also be hospitalists on the alongside midwifery unit. And then we have some casual staff who are from the practices that are supporting us. So they love it. It's a different way of working. Physicians love the collaboration. The trust has just exploded exponentially. I never imagined. I thought we had a pretty good relationship already with our physicians and other staff, but it's definitely improved a lot. It also has really helped us appreciate what happens at the hospital level that goes into planning and policies. So we really have a seat at the table now. So it's really great. And I won't take my full 10 minutes because I think we are probably running out of time.
We're good for time, Stephanie. So
we are.
you are,
okay.
yeah, we are good for time. But thank you, and it's so nice to hear across all of the projects that we've heard from already, just about the impact, the positive impact that these programs are having on interprofessional relationships, and for the profession's sort of visibility and respect and credibility. So I'm going to turn to you now, Lindsay, and it seems both of us have recovered from our internet glitches and we're back. So We're interested in hearing about your program and its strengths.
Great. So as I mentioned in the introductions, since January of 2022, my full-time role has been no longer caseload midwifery, but running what we call the Well Newborn and Parent Clinic at Kingston Health Sciences Center. So it's for all of the babies, again, that don't already have midwifery care. So there's about 2,000 births a year at KGH, and 500 of those already have midwifery care, but the other 1,500 are under physicians, a good chunk of them with MFM, because we're a level 3 tertiary center and the referral center for the region. And we have a level 3 NICU, so some of those are quite complex, but about last year alone, we saw 900 dyads. So we do see, between the midwifery practice and this clinic, like 75% of all the babies born in our community, which has been really, really neat. And so it is a 7-day-a-week program as well. It's in the obstetrics and gynecology ambulatory outpatient clinic setting, down the hall from labor and delivery and the postpartum unit. And the referrals come directly, they get booked just into the system on discharge from hospital. And certainly early discharge is one of the routes into the clinic if they need an early discharge visit with the newborn screening, et cetera. Very much bilirubin drives a lot of the visits for follow-up and timing. A good chunk of our clients don't have family doctors or primary care, but they do, even if they do, they have a hard time getting in to see their doctor within 1 to 3 days. And none of the practices have the ability to do bilirubin testing. So it's really becomes otherwise known as the Billy Clinic often around the unit. But certainly a lot of feeding support. Each visit is an hour for the parent and the baby. Sometimes it's just the baby. Sometimes it's just a parent visit, but typically parent and baby. The reason it's not always the parent is that we do get all of the babies involved in children's aid and other, interesting arrangements come to us as well. Kingston also happens to be the referral center for all of the evacuated Indigenous Cree families from the James Bay coast. So they all now, because of some of the closures and capacity in Timmins and North Bay, all come to Kingston to have their babies. And they're here for sometimes like a month or two to be, including the postpartum time. And previously, so prior to January of 2022, any new baby that needed a checkup that didn't have a family doctor or needed a Billy check would go to our urgent care setting or return to the inpatient unit for a nurse to quickly draw a Billy and so now that all of those patients come to see me and our team in the clinic. So that has been really eye-opening and interesting to learn more about that population and the care needs there. So yes, we just adapt. We get paid a little bit differently because we're not yet an EMCM. We're hoping to be approved as one, but this is technically coming through Schedule Q funding through Community Midwives of Kingston. So all of the midwives are paid per hour of work that flows through the born invoicing system through Schedule Q to our transfer payment agency, which is Ottawa Southeast Community Health Center. And Kingston Health Sciences acts as our partner in terms of support for a space as well as supplies, helping to kind of work out the logistics and such, but we don't really get much admin support or anything from them other than unit clerks booking in those appointments. So that's basically how it works. I do see babies and families up till about 6 weeks if needed, because a lot of them don't have those care providers. But a huge part of my role has become patient care navigating in the system. So I've become the source of the community to figure out where to send unattached babies. So how to refer them where, who's taking new people. A lot of interesting connections have been made through that, just learning how the communities work, where to find. So there's very little places taking on new patients. So anyway, I'm the the first stop for them before they, I get to refer them on to somewhere that will take care of the baby and make a safe plan with them for follow-up. So that's been really rewarding, and also has, to skip to the benefits, has been a huge improvement in our community integration and understanding of how other people work in the healthcare system, what we do, what family practices are doing, what NPs are doing. There's a lot of NP-led clinics now that are absorbing the similar problem of no primary care providers. So from a benefits point of view, certainly all of the clinical care that we've talked about just becoming the standard for postpartum, that families are actually getting regular postpartum care, avoiding trips into labor and delivery, emerge, urgent care, a lot of feeding support, and that care coordination. And to harp on the benefit for midwives, it's been enormously beneficial just for me to have an alternative model to work in our community and to be able to make an income as a midwife and have a different leadership role, and has been great. And we have 4 or 5 other midwives that still do caseload midwifery that jump into to cover days when possible, and that has been really interesting for them as well, and another source of income as well. And I can't say it's a coincidence that in this time, we've made huge strides with integration with the neonatologists and the family doctors, the obstetricians, to the point where recently our 2 biggest challenges being full scope and limiting our privileged numbers, that in the past year has now changed, and they can see that there is no wise reason to be limiting midwives' capacity in the hospital. So gaining their trust, and also knowing that having midwives at your hospital is going to lead to value and benefits and innovation. And honestly, even just as a way to thank us for absorbing the load, the neonatologists have been so appreciative, because they otherwise provide that care to otherwise healthy babies. It's not the best use of resources for a tertiary neonatologist, right? So those are the big things that certainly it's decreasing the length of stay in hospitals, and the resources are really tight on our postpartum unit in particular. They're also a medicine unit. They're doing gyne-onc post care. They just truly don't have time to help with feeding and the typical normal needs of a postpartum parent. So being able to at least absorb that in the outpatient follow-up setting. And as much as I thought it would be less rewarding to not see continuity with clients, I, for one, actually see them sometimes more than I would have seen them in a shared care model in my other practice. I'm sometimes seeing them 6-7 times in postpartum visits. And it's quite incredible, actually, how much you can make a connection and how important it is. That 1 hour that they spend with me, they've sometimes said is like the best healthcare experience they've had through their whole pregnancy and birth journey. So that feels really rewarding. And so I could go on, but those are some of the main strengths I see.
Thank you so much, Lindsay. It's also really interesting listening to all of you, just thinking about it back to some of the things we've heard in the first couple of days of the symposium as well, and particularly yesterday in our discussion about the sustainability of the profession and the different ways in which each of you are working and contributing to the system. I think it's all making very positive impacts on the sustainability of the profession. You've talked about the benefits of having flexibility in how you're working, and the rewards of being able to not just build positive relationships with other providers, but like really actively filling gaps in the system and providing really appreciated care to the people that you're serving. So I am looking forward to hearing questions from our audience. And at the moment, it looks like we had a few that were posed as people were speaking, and those have been answered in the chat, in the Q&A. But if people from the audience have more questions, please feel free to put them in the Q&A now. Okay, so we have a great question, and this is for all of you. Can you share with us what are some of the challenges that you faced initially pitching your program proposals to your respective hospital administrators? And I know some people here were involved in the pitches and others may not have been, but this is open to anybody. Natalie?
I have been a part of it since like we did the original EMCM application. Truthfully, I didn't have a problem, but that's because I like thought I was like, what do they want? That's what I have to deliver to them in this pitch. So what is going to be really good for the hospital that will in turn be good for me and in turn be good for the community, but framing it as what they would like to see and using those like buzzwords and those keywords that they want to hear made it really easy. And we worked to do our application in a really collaborative and supportive way by really focusing on what were the gaps on our unit that we weren't delivering and how could we improve that service delivery, that it made it tremendously an easy process.
Lauren? Thanks, Natalie.
Yeah, I was also involved from sort of conception of the idea and writing the application all the way through implementation, and am now working in it. And I would say that in order to get it up and going, it required like just constant, you know, you're pushing it through with your own sort of strength and and grit to just get it done. I guess nobody is going to care about getting the program implemented as much as you are if you are the one who wants to see it. And so it was a lot of problem solving and yeah, just sort of speaking to various people to sort different problems out. And they're silly little problems that you don't think are an issue, but our hospital had never had a midwife as an employee before. So immediately, you know, when we just went to post the ads, they, you know, HR was like, oh, we don't know what this position is. We've never had a so-called midwife before. So there were lots of just little things that we had to work on and address. And it's things like pay scales when there are no other midwifery employees, and then what do you get paid? Fortunately, obviously the infrastructure from the ministry through the EMCM does have some parameters around that you can use as documentation, but you know, just getting built up in the system. We do, you know, all of our schedule is all electronic, and we wanted to be able to use it out in the community as well. And there are all sorts of IT sort of safety device issues around that, and using, you know, internet and things like that. So it was all sorting all of that stuff out is a lot of work. And so I'm recognizing that it takes capacity to be able to implement these programs really successfully, especially when they do become more complex or involve, you know, outpatient settings outside of the hospital. You know, there's a few programs in the hospital that do outpatient home visits like dialysis and some psychiatry units as well, but it's still relatively uncommon. So there's a lot to navigate that way.
Thanks, Lauren. I'm going to maybe move to a bit of what has been noted for us in the chat, just to kind of build on. We talked a little bit about payment and how that there is a bit of guidance through the funding for the EMCMs around how much midwives would be paid. But there's also a question here about, for those of you who are working as employees, whether you have a manager and how that works. Natalie?
Yeah, I have, my manager is the nurse manager for our obstetrical unit. And so when I need to, I report up to her, and then she reports up to the chief, and then we report up to the maternal child committee. So I also sit on maternal child in my lead as the Well Baby Clinic. And I was going to say that the hourly wage, like the ministry provided like a really good, they laid out what the salary was. So it was quite easy for our hospital to say, oh, okay, great, that's what we'll pay you. And I didn't encounter any like pushback about that.
Lauren?
We also have a manager. I feel like she probably feels she's long suffering dealing with us as we transition from, you know, self-employed people to being employees. And her sort of constantly reminding us, like, you can't do that, or yeah, she's very, very hands off, and really kind of let us do our thing and create the program that we wanted, and has been our sounding board for some of the hospital processes. But yeah, it hasn't been an issue.
Great, thanks, Stephanie.
I feel very fortunate because my manager is actually the manager of the AMU, and she's another midwife. So she gets what we do, super supportive. She's not a typical manager, like, micromanaging us. We still have a lot of autonomy, but she's incredibly supportive in getting us what we need. So really grateful.
Thanks, Stephanie. Chantal?
I just want to share that at Montfort, when we started in 2005, we had some pretty good leads, like clinical directors of the unit and whatnot, that really, really set the pace for having midwives integrated into the hospital. There were no midwifery presence before. Obviously, we became very solid and established ourselves as midwives. And so when we continued in building up the postnatal program, basically the midwives who were there had the leaders already present, already believing in midwifery care, seeing the stats, the good outcomes, all of that, and then just trusted that this was going to work. The other thing is that then afterwards, those clinical directors left, new came in, but the same kind of engouement, like the same kind of drive, carried on afterwards. So that has been very beneficial. Kind of like what Stephanie was saying, is that we have a lot of autonomy. They are not like that. Clinical director is not micromanaging us, but we do have monthly, meetings and whatnot. If anything, I would say that there's a lot more visibility of midwives since in the hospital, since this program is going. So yeah, it's working. In terms of what Natalie was saying and financial, like how we get paid, it was all organized through what was recommended through the AOM and the ministry and stuff like that. So, yeah.
Thanks, Chantal. And just there's another question. So we have a lot of members of the audience who are familiar with midwifery in Ontario and know what this acronym is that we've been using, but I recognize that there are many of you who might not. So EMCMs stand for Expanded Midwifery Care Models, and this is these are things that have developed in Ontario over the last 5 years. Prior to 2018, midwives in the province all worked in one funding model where they were paid for a full bundle of care called a course of care, and worked in community-based midwifery-led practices and a continuity of care model. And in 2018, the ministry provided funding for midwives to be able to be hired to work in other kinds of programs like the ones that people are sharing about today. So that's what EMCM is. I'm going to go back to some of our questions in the Q&A. And there's a question here about, given that the EMCM bucket for funding is limited, what do people think about whether there might be a way for us to convince other funders to fund EMCMs? Any thoughts on that? And I think the idea would maybe be hospitals. Lauren?
That's exactly what I was going to say. I think, the hospital employs a whole range of professions to provide care. They have nurses, RPNs, NPs, a wide range of people who work and provide care. And I think that midwives could fall into that as well. And so some of it comes down to the evaluation, and obviously I don't need to reiterate this one. Liz presented a really fantastic evaluation of EMCM work in the first day of this conference, but having those sort of financial cases, but also outcomes-based cases to make to your hospital management to be able to advocate for that is a method that would be the first thing that I could think of.
Thanks, Lauren. Natalie?
I think you would approach it also like with everything that Lauren just said, but also as like a cost saving strategy for the hospital. So you're going to say, here for this salary, like for this modest investment in me as my service and skills, here's what we can save you from hospital readmissions, outpatient home visits, early discharge visits, all of those types of things, and say that it's a better investment for them to invest in you than to continue to fund all these other things, and it's better care. So it's delivering improved care in the right place at the right time for an actual positive effect for your budget.
Thank you, Natalie. Lindsay?
I was just going to say, because I think I'm the only one that it's not in an EMCM model currently. Again, hopefully we do move that way, but it actually has been great to just really start slow. And very initially, we started this actually just on the weekends at the beginning of the pandemic out of our clinic, and really just responded to what the needs were of the hospital and the physicians, and of course that translates to the clients and patients, but pretty much showed how valuable we could be, so that it was actually the head of pediatrics who approached me to say, how can we get that funding? How can we support you to get that funding, right? So as soon as you can almost make yourselves impossible to imagine now care without us, I do wonder if we don't get funded for EMCM, whether the hospital would be willing to start to pay for us. Of course, they're not going to pay for us if the ministry is willing to fund us a different way. But and starting slow, it's allowed us to really want to be able to understand and imagine, because it's a really big program to have to develop and imagine how that would look and work and how many hours. And so to be able to start a little bit slower with just the outpatient clinic, and we're hoping to move into more inpatient care and home visits as well, but to just start there and really understand the system before we really level up the program. So again, what I was going to say is that I've learned so much just about all of this is about relationships, right? And that's how things, unfortunately, and to our advantage, work in the system. Your relationship level at your TPA or whoever is funding your practice, if they're convinced enough about the need and also have the hospital support. So the hospital calling our TPA to say, we need this program, we need midwives. They love to be able to help out a hospital and help midwives at the same time. So that relationship with our TPA really came through for us in this situation.
Thanks, Lindsay. It's really interesting to hear, just about some of the differences, some projects starting kind of with a full plan at the beginning, and what you're talking about with the idea of starting slowly and just gradually building and adding. Kind of building on that, there's a question in the Q&A about what you would recommend to be the first steps in creating programs in other communities. Anybody want to take a go at answering that? Stephanie?
I would say from the beginning, you have to clearly identify who your early adopters are going to be and your champions. Ideally, some, physicians in the hospital. If you can just get one to really be as passionate as you are, that's what happened with us. We had a neonatologist who had worked in a hospital in the States that did early discharge, and she was all over it, which you might not think, because being the specialist, you might think she was going to be the most nervous, but no, she really understands what midwives do. And so we're really lucky to have her on our side, as well as the heads, both heads of our department, so pediatrics and obstetricals. So just really make those relationships. I think it worked well because I was already working at this hospital for 7-8 years, and so I wasn't a stranger to the organization. So I think that really factored in.
Thanks, Stephanie. Lindsay, did you want to answer this, or is that still your hand from last time?
It's an old hand, but I have thoughts, of course.
Okay, go ahead.
I do think it is again about first really understanding the problems that we're trying to solve, and it has to be multi-pronged. So it has to be solving problems for the patients, for the hospital, and for the midwifery practice or the midwives that are needing that program. Because as Lauren said, it takes an enormous amount of energy just to even get this up and running. So you need people that are really invested in it personally and professionally. And making it look like a win for our program director. Really, this has become his win, right? And I'm happy to share that win with him. But for him to get praise from his corporate leaders and management about things that he's done, right? So to find ways that other people can benefit from it, I think really, and again, it's going to be very individualized based on your community and circumstances, but figuring that out before moving forward. And it may not be the perfect ideal program that you imagined, but if it's really matching the needs of the community, then it's going to work.
Stephanie?
Yes, I would add to become familiar with the strategic goals of your organization and see how your program will align it with it and really push from that angle. So it was really nice to see that one of the goals of our hospital was to expand care beyond our walls. Those words were actually in our 5-year plan. So that was seemed like a pretty easy way for us to slip in with our program. So everybody won.
Thank you. Natalie?
I was just going to say, and also look at the Ministry of Health's performance measures, like what's the ministry's strategic goals, and align with those while aligning with your institutions as well.
Great. Really, really wide range of sage advice from all of you. Is there anything else that anyone would like to add? Chantal?
I would just say, don't assume that people know how midwives work and what our work is all about. Like, you just have to spell it out so that people absolutely understand the plethora, like la vastity, like how wide we cover, and that it's just not, it's a dyad, and the worth of our work. Know our worth. That's it.
Thank you. Any other things to add on that one before I go to another question? So the next question is about what are some of the things that we could be teaching in our midwifery education programs to prepare students for providing care in these kind of models? Lauren?
That's a great question. I really love it as someone who is sort of interested and who does a lot of research in continuing professional development. But I think it's actually just teaching sort of a really strong belief in growth mindset and a really strong belief in continuing professional development and the way that it's important for the rest of your life. So there's really, I would say for our birthing clients, one of the most common reasons that they're under MFM care is because of cardiac issues. And so we have a lot of cardiac patients who need, some fairly complex care plans antenatally as well as postpartum. I certainly didn't learn anything about, managing heart failure in pregnancy in the MEP, and that's okay, but you can definitely learn all of that in a variety of ways once you're out working with that population. And the nice thing about having good, strong care teams is that you have cardiologists, you have, OB medicine, you have MFM that you can ask questions to. So we've sort of combined it from a combination of leaning on our colleagues to learn, and they recognize that this is a big learning curve for us, as well as doing all of our own work, our own research, our own learning, and yeah, it's amazing what you can teach yourself and learn when you become really immersed with that population. So yeah, I think it's just recognizing that you have the capacity to teach yourself all sorts of things throughout your career. and having that growth mindset and not being afraid or nervous to do that.
Thanks, Lauren. Lindsay?
I love that, Lauren, about the growth mindset. I also find it just individually really just rewarding and interesting to be caring now for all of these high risk medical patients. And as much as I also, deal with uncomplicated, it is just an interesting intellectual challenge and fascinating to understand more about those higher risk pregnancies. And I was also just going to say that learning more about the healthcare system itself and really understanding the process, I think is something that we could learn more about in the MEP, and just having more interprofessional placements like that to really understand how things actually work, to be able to adapt and meet those needs, less in our silos. And a big part of my role is I precept a lot of NP students and nursing students in this role, and also there'll be some family medicine residents, and so just more interprofessional education and right from the start so that we can learn more from each other.
Thank you. Stephanie?
I think introducing students to very basic principles of change management and really focusing on leadership education would be very beneficial for a role like this, just management principles. So hopefully we could see more of that.
Thanks, Stephanie. Any other thoughts from anyone on the panel? Okay, I'm gonna just draw people's attention, for those of you who are on the Padlet, to a question that somebody has posed there that I think actually is maybe a bit beyond the scope of our panel to be able to answer. Somebody's curious about whether or not there are similar midwifery-led postpartum care programs operating outside of Ontario. So I do know that in BC, because of the way that funding works, midwives are able to bill just for the postpartum portion of care. And there are midwives in BC who are focusing on providing postpartum care, but I don't know details about how those programs work. So if there are any of you in the audience who are involved in any of those kind of initiatives, and you're willing to share some details about that on the Padlet, people would be very curious to hear about your work. And it's a great question that, maybe we might be able to explore in future symposiums, looking at what's happening in other places beyond Ontario as well. Okay, a couple of sort of fairly specific questions related to funding type questions. One of them is whether people feel like you're being remunerated appropriately for the work that you're doing. If you compare it to sort of the postpartum segment of work in continuity models. Natalie?
I feel very fairly compensated. I feel in our budget, you get your salary laid out, which is about the salary of a full-time midwife. And there's money for benefits. And so you have benefits funding covered, and I'm in the HOOP pension plan, at our hospital. So I feel like it's been very fair. And because you're in a hospital benefits setting, the benefits are cheap. So it's not as expensive as when you're going through the AOMBT, which has been a nice cost offset.
Thanks, Natalie. Lauren? And just for people outside of Ontario, Natalie just mentioned the AOMBT, which is the benefits trust in Ontario that's organized by our professional association, the AOM, the Association of Ontario Midwives, and they coordinate and organize benefits for midwives in this province. Lauren.
Yeah, I agree with Natalie, and in terms of our funding setups, it's exactly the same as far as just employee, you have a salary and you're compensated that way. And I think the biggest change for probably most of the people on this panel is not providing intrapartum care, and therefore not leading to these, sort of potentially very long births at all hours and days. So I think removing that, and I don't know actually how much of a typical midwifery salary goes to sort of compensating that challenge and that toll that takes on you. But removing that from the equation, I think really helps bring a lot of, balance. And I think probably every individual person would feel like that work, it should be compensated in maybe a different way. Like that might vary depending on how challenging people find it in their lives. So without that, and just sort of working 7 days a week, but daytime hours, I think that's a big difference, which might go towards making the compensation feel fair. The one thing that I think some people shifting to employee models might notice is that it is very different than how you work as a midwife, where you might go these stretches in midwifery call model days where you don't have anything going on, and so you're at home. You can do all sorts of stuff. But when you're in an employee model, it is very much like Monday to Friday kind of set hours, 9 to 5. You're in the space, and that's very different from how it feels to be an MPG midwife. So it might take some getting used to, and it might actually not be for everyone to sort of have that Monday to Friday 9 to 5, or in our case, it's technically rotating through 7 days, but it's the same idea.
Thanks, Lauren. Yeah, that's a great point, just about what the difference can feel like when you have much more diversity in your schedule when you're on call and working in a community-based practice. Okay, we have a couple more questions and we've still got a bit of time. So one of the other questions was about the funding for insurance, and just whether people felt like they had any questions about whether the cost of insurance for the work that they were doing was appropriate. Anyone want to comment on that? Lauren?
Yeah, I can't say this is an area of expertise for me, but I don't think that we pay particularly high insurance premiums, generally to begin with, even as intrapartum care providers. So to me, it doesn't seem like it should really change that significantly without the intrapartum care piece. I do realize that, a large portion of sort of the pay that HIROC puts towards claims does come from intrapartum care events. And so without that, I'm not sure if you could really make that calculation, but I don't think that it comes from intrapartum care events necessarily involving midwives in such a large degree. So yeah, so that's my thoughts on it.
I'll maybe just chime in briefly on this one. My understanding is that I think one of the other factors that has played into the fact that we don't yet have other types of models of insurance that are different than the rates for people providing intrapartum care is that some of the higher cost claims historically in the past were related to newborn outcomes around hyperbilirubinemia as well. So for postpartum care, that would definitely be relevant in this context. Okay, we have another question. So somebody here has made a comment that it's interesting to hear about employee style funding for midwives in Ontario having allowed people to work in new ways. And they're curious about whether or not this might have implications for other provinces where midwives already are working as employees. Does anybody want to comment on that, or any reflections there?
If anything, I would just say it seems like it could be easier to set it up because they already have a funding model where their employees and their sort of scope and what they're expected to do for that salary is already set. I think if anything, it would be easier, but it's almost like it would be part of like a sort of a system planning to decide, what scope of work could we shift into this type of employee. And instead of having this patient care pathway involve these other people, how could they involve, employee midwives instead? So if anything, I think it would actually be simpler, because I think one of the biggest barriers here in Ontario is, as many people have mentioned in comments, that there's a limited pool of funding for EMCMs, and that's sort of the cap on it.
Stephanie?
I think it would be a great way to make midwifery more sustainable for those midwives for when they're ready to move to maybe part-time, less hours invested in interpartum care. They would not have to take that hit to their salary if they could run some groups or work in the clinic and just kind of do like a 50-50 split or whatever works.
Natalie?
Yeah, I think if you graduate with a nursing degree, you can be a nurse on a unit, you can work in public health, you can be in a doctor's office. There's flexibility to use that education in different ways. And I think that is what I'm hopeful what we continue to see with a midwifery degree is that we have a unique skill and we have a unique scope, and we can do a lot. And so allowing midwives to work and practice in different ways in the same way that a nurse could choose it, she would like what her preference is. So I do hope to see it more in Ontario and in other provinces.
Thanks, Natalie. I'm going to turn now. We have another question, which is whether or not, or it's maybe more of a comment, and so I'll just let people reflect on that if you like, which is that there may be challenges in getting hospitals or health authorities to hire midwives in places where roles are traditionally filled by nurses or nurse practitioners. Any thoughts on that from anyone? See some nods. Lauren?
Yeah, I think some of it would probably just come down to cost benefit sort of analysis. And so obviously if there are more economical ways of doing things where the care is just as good, I think, systems have to, our leaders and our hospitals need to go with that more efficient method. But it comes down to also having maybe through some of this innovation, having evaluations of these types of programs that might show, as Natalie mentioned earlier, that potentially it could actually be a more cost-effective way of providing the care and entail better outcomes. And so both of those things, I think, can be prioritized, as part of that discussion and saying, maybe some of the care, and I think for our model, this is a really great example. There's no argument that people were getting great care with the maternal-fetal medicine specialists, but maybe it wasn't the best patient experience as they went home and had a ton of anxiety or didn't know where to go and presented to emerge. And so there was both that cost issue where they were, returning in really high cost ways to the system and having more readmissions, but also themselves are not having a great experience with that sort of fractured care. So you're sort of looking at some of those different calculations that would factor in. And I think it just becomes making a case that way and having some outcomes evaluations like Liz is doing and other people who are evaluating those models.
Thanks, Lauren. Natalie.
Yeah, I was just going to say that midwives are nothing but up for a good challenge to fight the system and prove our worth and demonstrate how we can help. And I completely agree. And one of the other panelists said earlier that it was easier for me because I knew my hospital, I knew the players, they knew me. I can appreciate that, but I also think that hard work and persistence and flexibility, and we think differently than a lot of other disciplines that, if they're like, Natalie, can you go do this? Yep, got it, on it. Where like nursing is very black and white and we're very gray, that I think that we have a really unique way that we can fill this role. And we just have to continue to demonstrate that until people are more familiar with what we do.
Chantal?
I think I just want to add that, oh my God, my thought is just gone. Sorry. But it came more from like the leadership, right? And as midwives, we know what we do. but people don't fully understand. You need the presence of midwives in a hospital. And as we're slowly, because this is just the start of infiltrating the system, this, like we think we are fully integrated, but we're kind of like working in silos when we're working in midwifery care and coming in with clients and stuff like that. And then I can see, coming from working into the community setting, now working into the hospital, how I'm infiltrating, like there are barriers, there are doors that are kind of like opening up, and having myself, like having a better presence. Somebody said that earlier, like just having a presence, like I'm here, I'm in the hospital, I'm present, even though I'm doing home visits and that most of my work is done outside, I'm still present, and people will start to really see the worth and the value of midwives, and that we can be definitely key players in being hired. It's not going to happen overnight, definitely not, but it is slowly building. I can see the momentum.
Thank you. Lauren?
Yeah, and I would also add to the question around, maybe RNs, RPNs, whatever, could fill these roles. I think something that is unique about midwifery and how we're trained is our flexibility to work both in the hospital setting and the community setting, and actually do both simultaneously. And one of the issues that was noted in our as we were researching and trying to create the model that we created, was that there was this huge sort of difference between inpatient, outpatient, as well as hospital and community-based services, and how they just sort of break the minute that you're out of the hospital. Now you need community-based services, and there's very little sort of communication and connection. And it was repeatedly mentioned by everyone caring for this clientele that sort of break in services was a huge area where people were lost to care, lost to follow-up, and where basically issues happened and inappropriate care, or they didn't access appropriate care. So I think that recognizing that issue in the system and the gap that they haven't actually been able to fill properly with RNs, RPNs, other people, and finding someone who can work just as well in the hospital as they can in the community and sort of seamlessly, I think that's actually a strength and a good selling point, and a way to say, there's not really many other people working as MRPs who can actually bridge that gap and provide that care. And a really great example that we had from our clinic is we had someone who is unstably housed and had no phone access and no transportation, who was very, very, very sick antenatally. And basically the problem was just they couldn't get her to an appointment. So she had all these appointments with all these specialists who are all very worried about her, but they had no way of reaching her and no way of getting her to the hospital. And it was like, well, we can drive to her place where she's staying and literally give her the time of her appointment and bus tickets to get there. And lo and behold, she shows up, right? So it's that ability to sort of go between the two locations and really access patients where they're at, access them in their homes, and bridge that. And I think there's not a lot of other practitioners who are working that way, but it's a really unique skill that midwives have.
Thank you so much. So we don't have any questions left. We have a couple of minutes, and I have one last question that's maybe a big one, but maybe if just one person wants to take a short answer at it, which is, and then we'll wrap up, which is, I think we've heard lots about the benefits of these models. And one of the things that came up in the conversation yesterday about sustainability of the profession was that as we increase and add flexibility to the way that midwives are working, that we do probably also need to make sure that we don't lose the continuity of care models that we have. And so I'm wondering if any of you have any pithy thoughts about, how we might do that as we also look at, expanding the number of people in the province who are having access to midwifery care through these kind of programs. Anyone want to?
I don't think we're ever going to lose the beautiful, traditional, amazing model of care. It was something that I treasured and loved working in. It's just life circumstances changed a bit for me, and I couldn't keep working in that model. But I don't think it's going anywhere because it's so fabulous that there is people who can continue to carry that torch. And perhaps when my kids are grown, I'll be able to go back to it. But when you're at these unique life stages, you have to have alternate ways to make an income for your family with your experience and your expertise.
Thanks, Natalie. I think I will end it there. That's a really lovely way to kind of sum up the value and benefits of all the different ways in which midwives are working. And I really appreciate each of you sharing your wisdom and telling us more about the work that you're doing. It's been really interesting to hear and to hear about the similarities and differences across your different programs. So that brings us to the end of our panel for today. And I would really encourage people to join us tomorrow, starting at noon. We have keynote speakers, Dr. Esther van de Jonge and Liesbeth Kool, presenting on the transition into practice experiences of newly qualified midwives in the Netherlands, followed by a research showcase at 12:35 by Dr. Anne Malott, one of our MMRC members, on tackling transition together, evaluating a mentorship program for new registered midwives. So a nice similarity there in terms of the topics. And then we'll wrap up tomorrow with a student showcase from Jen Goldberg on queering midwifery, a critical narrative inquiry into the experiences of queer and trans midwifery service users in Ontario. And I also want to just take a moment to encourage people to please complete the survey with your feedback to help us improve next year's symposium. And I think that Raj has shared the link to that in the chat for people. And again, we're really happy to have had so many people join us today, and we look forward to seeing many of you again tomorrow.